Hi, hello everyone, and welcome to the second lecture of the Pearls Lecture Series of 2024. My name is Bilal Hafiz. I'm a final year medical student at the University of Melbourne. And before we get started with our lecture today, I would like to quickly talk about Pearls as an organization. So Pearls stands for POCUS for Emergency and Acute Care in Resource Limited Settings. It started in 2022 when the inaugural Pearls course was run in Port Vila, Vanuatu, where Vanuatu physicians received handheld ultrasound probes to plug into their smartphones, and they undertook 3 days of vigorous ultrasound training from a team of visiting physicians as well as sonographers. Now, this included Dr. John O'Henry, who's part of the lecture today as well. And since the first course, what we've done is we've successfully ran 3 additional courses that spanned across Vanuatu, Papua New Guinea, as well as Tonga. Now, after the courses, these upskilled physicians, they continue to receive feedback, mentorship, very soon ongoing image review, and this all occurs via remote imaging platforms, as well as the Pearls lecture series that we're on today. So today we'll be hearing from Dr. Lori Stolz on POCUS in MSK. So Lori, welcome. Thank you so very much for taking time out of your day and of course, well, your night actually, and having a chat with us about such an interesting and not really talked about topic as well. Now, before we get started with your lecture, we were hoping if you could perhaps share some of your light, shed some light on your journey within ultrasound, how you got here, and how you've made it a part of your current practice, as well as your teaching. Thanks.
Thanks for having me. I really appreciate it. So for all of you, I'm Lori Stolz. I am the ultrasound director and an emergency physician at the University of Cincinnati. My journey with ultrasound is, my medical school training was very heavily focused on ultrasound, and that kind of piqued my interest. And then after my residency training, I found that I used ultrasound a lot and I found it very gratifying, but I didn't think that I was going to make a career out of it. But my ultrasound director came to me and said, we have this position, take a chance on me. And I went for it. And now, my gosh, we're now 13 years after that. And and so now I've made an entire career out of doing ultrasound in the emergency department. And right now I train fellows, I train residents, I train our faculty for ultrasound. Um, I work in a very resourced setting. We're like the tertiary care center, we're a trauma center, a stroke center. We get to do TEE. We have all kinds of ultrasound at our fingertips, but I've worked quite a bit with a program in Africa, where Uganda specifically, whereby we teach mid-level providers how to provide the first hour, 2 hours of emergency care. And in that setting, ultrasound is one of the most valuable tools. And so I learned a lot working there. I learned a lot about like the expansiveness of how ultrasound can be used. I learned a lot about um, the nuances of using it in a way that is maybe outside of the realm of a tertiary care center. So it's been a while though. I haven't got to travel at all since the pandemic happened. So steer me back if you feel like you need the tips and tricks of your setting, and how things might work where you are. So with that, I'll get started. My lecture today is about musculoskeletal ultrasound and mastery of musculoskeletal ultrasound. Let me get my thing working. There we go. I can you guys see my screen okay? Can you give me a thumbs up if you can see me? Okay, cool. So my objectives for our lecture is I want to go over the general principles of musculoskeletal ultrasound, kind of the sonographic anatomy, the best ways to use it, how it may help you both most. And then we'll talk specifically about different use cases. and using it for assessing for fractures, using ultrasound to do hematoma blocks, using it for shoulder dislocations and intra-articular injections, and then also femoral nerve blocks. So in general, the scanning principles that make musculoskeletal ultrasound a little bit different than the other ways that you've used it is it's a little less proscripted, right? You rather than imaging this part of the aorta and then that part of the aorta, you are a little bit more open-ended about what you're looking at. Um, there are lots of general principles, and so we'll start with those. So you want to image all the way from the origin all the way to the insertion of whatever it is that you're looking at. So if you're looking at a particular bone, you want to image all the way from one end to the other. If you're looking at a tendon, all the way from the origin to the insertion. And same for ligaments, same for muscles. Um, the patient can often guide you to where the pathology is, unlike abdominal organs or thoracic organs. They'll be able to point exactly where their pain is and be able to guide you to what you might be looking at. You have to be a little bit more open-ended with your ultrasound because of that, because you might not know exactly what you're going to find when you first put the probe on. The most brilliant thing that I find about doing musculoskeletal ultrasound is that you have an available normal to you most of the time. I mean, people do have like bilateral, both one forearm fractures or bilateral femur fractures sometimes, but most of the time you have an available normal at your disposal. So if you don't know what you're looking at, you can always look at the other side to determine what you might be seeing, what might be different. I think that no musculoskeletal ultrasound is complete until you've evaluated both sides. So always keep that in mind. Anything that you're imaging also needs to be imaged in both the longitudinal and the transverse plane on that piece of anatomy. Whether it's a bone, whether it's a tendon, one view is no view, and then dynamic images are a must. You can move the joint, you can move the muscle, you can move the tendon, and so this is very, very helpful. One, to identify pathology, but it's an ability that ultrasound has that other imaging modalities don't have. You're not going to necessarily get dynamic CT. Sometimes we do get dynamic X-ray though, and I find I really like fluoroscopy because of that dynamic nature. So first and foremost, we should go through the sonographic anatomy. What will you see on ultrasound and how to differentiate things? This is the basis of your building blocks to be able to recognize pathology, is to be able to recognize the normal anatomy. So we'll go through this just a little bit. So first, we'll start with the easiest, bone. Bones are very easy to recognize because of their very hyperechoic nature. You get a hyperechoic line with a dense dark shadow behind it. They do not allow any of the ultrasound waves to pass through them, and so you get no imaging on the far field from a bone. Now, there are some nuances there. In general, we are looking for the main pathology is a fracture. And so a fracture is going to look like a break in that bright white line. So a break in the cortex of the bone is an indicator that you have a fracture. And here we have a distal radius and a fracture in it. So you can see I'm going to get my pointer. There you go. So you can see the really hyperechoic line that makes up the cortex of the bone, and then we see a little break within the cortex there, and then we have the continuation of the rest of the bony cortex right there. Now, two things to remember that can trip you up as you are looking at bones, however, is both cartilage and growth plates. And you'd be like, I would recognize what's what. Well, it's a little bit difficult sometimes. So articular cartilage can appear very, very anechoic and sometimes can be mistaken for an effusion. The differences that make it different than fluid within a joint is that it tends to hug the bony cortex. It tends to match that curvature really nicely, whereas effusions tend to bulge out. And over time you'll learn the different locations where effusions are expected to be and the different locations where articular cartilage is expected to be. But young learners, people that are just getting started, this is a frequent trip up, is that they'll try to tap the articular cartilage, and nobody wants to put a needle in articular cartilage. Another another difficulty can sometimes be growth plates. So you can see the growth plate right here in a child, and the growth plate is a cortical break, and so you can easily mistake it, the physis for a fracture. Knowing, of course, where they're located can be very, very helpful. Easy trip ups there, though. So we discussed what bone looks like on ultrasound. So now let's discuss what muscle looks like on ultrasound. So muscle tends to have a very heterogeneous appearance. So you'll have areas that are very hyperechoic, you'll have areas that are very isoechoic, all kind of mixed together. One thing that I find to be somewhat helpful is that muscle does look just like gray and white um, gray and white meat. Sorry for the vegetarians that might be in the group. But if you look at muscle in the short axis plane, you get this very marbled appearance. Um, and it looks just like a steak cut in, in a transverse plane across the muscle. And then when you look at muscle in the longitudinal plane, it has this very striated appearance and long lines, and it looks just like meat cut along that plane as well. So the most common muscle abnormalities that you're going to see is going to be a hematoma. But when you're looking for pathology within muscle, you're looking for any loss of that pattern. So the loss of that marbled pattern, we can kind of see that's over here, like this is the normal marbled pattern that you would expect. And then within that, there's a loss of that pattern, and there's an area that doesn't match that marbled appearance of that muscle. And then when we turn it into the longitudinal plane, then you can see this area here that it just doesn't match that pattern. And so you may have areas within the muscle that are hyperechoic. You may have areas that are hypoechoic. You know, the appearance of a hematoma within a muscle, whether it's hyperechoic, isoechoic, or hypoechoic, depends on how old it is. And so a hematoma within a muscle that is more acute is actually sometimes going to be more hyperechoic, and then it becomes somewhat anechoic, and then as it's in the final stages of healing, it becomes more isoechoic. So this one over here that you're seeing in this picture, this one's probably a little bit older of a hematoma in that space because it has such a mixed appearance within it. And then the other thing that you might see within muscles that's pathologic is that you may see pockets of fluid. So muscle tears, are going to have pockets of fluids, but also hematomas in an earlier stage. And so we can see here, let me start up that video too. So we can see here, this is an example of a patient who had fallen onto their hip, and this is their thigh muscles. And I found that this one was really subtle. This was a bit of a challenging case, and you can see within the muscle valley here, this area comes up here, it just does not match the normal pattern. And then when the probe is turned 90 degrees in an orthogonal plane, you are seeing that same kind of area and the loss of that normal pattern. I like to show you these ones because sometimes the subtler cases are really difficult to identify, and you may not see it in every scenario. Sometimes in lectures, we like to show the most perfect and beautiful pictures, but the reality of life is that we don't always see it that way. So we can initially see, hematomas look anechoic, sometimes with debris or clot. If there's lots of clot in the very acute phase, you can see hyperechoic areas within it, and then with healing, it becomes somewhat inhomogeneous and isoechoic again. Um, and this is another example of muscle tear. So the fluid that you're seeing here is actually between this patient's gastroc and soleus muscle. So you're seeing it in a short axis plane here, and then a long axis plane here. This one was done about a month ago by one of my ultrasound fellows. They were convinced that this patient had an Achilles tendon rupture, and then they had found uh, this fluid pocket here. And so this was from a muscle tear, a bit of a shear injury in between the gastroc and the soleus. But the fluid really gives away where the pathology is. Okay, next, tendons. So tendon tendon normal anatomy tends to be very fibrillar. So tendons are made up of multiple multiple small linear hyperechoic lines. You have hypoechoic areas that are also linear within them, so it tends to have like a layered appearance within it. When you turn into the short axis plane, they tend to look like little cookies. I think they look like a little bit like ovaries. I don't know if you've heard that. Ovaries look like chocolate chip cookies, um, but I think that they tend to look a little bit like ovaries, and that they have some areas that are hypoechoic circles and then some isoechoic mixed in with that. So on this image here, you can see this is a tendon here, and it's starting out kind of flat as it's coming from the muscle. And then as they're going more distal to the insertion, then you're able to see that it's becoming more rounded. And so that's very typical of a tendon. Remember, tendons connect muscle to bone and ligaments connect bone to bone. And so tendons are going to have a more flat appearance as it's coming from the muscle, and then tend to be more rounded as it gets to its insertion point. Having ultrasound at your fingertips can sometimes be a little confusing because um, you we often forget our anatomy as much as you learn when you're in medical school, remembering what all of the various tendons and muscles of the forearm are. And so it's there's no shame in looking up the anatomy in an area as you get to know the sonographic appearance of the area. And the other faculty in our department kind of joke that the ultrasound folks seem to know their anatomy the best because we're always looking at it all the time. So make that as something that you work on, is looking at the sonographic anatomy adjacent to the textbook anatomy, and it'll make you learn your stuff very quickly. So anisotropy is very important to know about when you're learning about tendons and ultrasound of tendons. So it is the property of being directionally dependent. So tendons exhibit this property of anisotropy. And so what that means is that when the ultrasound waves leave the probe, they have to be perfectly perpendicular to the tendon in order to image it well. After you leave this perpendicular plane, if you rock your probe or if you have an oblique angle on the tendon, then the tendon becomes very hypoechoic very quickly, and it can mimic what a tendon rupture looks like. So ways to fix this when you're scanning is you can change the angle that you're scanning at, change the angle of the patient's anatomy, or rock or fan your probe so that you are very mindful of the angle at which the ultrasound waves are hitting the tendon. And I'm going to show you now pictorially what I just said. I'm not a learner that learns very well by words. I learn very well by seeing, as maybe a lot of you guys do, since you are ultrasound aficionados. But when the ultrasound waves are leaving the probe and then encountering a tendon and this very fibrillar structure, then the ultrasound waves then can bounce off into Never Never Land where the ultrasound probe can't pick them up. And so you get this dropout, you get black areas there. This is not good for our imaging. It means that we can mistake areas that are hypoechoic or anechoic. We can mistake those areas for tendon ruptures when there's no tendon rupture there. It's just the artifact of anisotropy. But what you do want is as your ultrasound waves leave your probe, hit the tendon, and then bounce back to the ultrasound probe, you get a full image. And this is going to give you a beautiful image of a tendon. So I'm going to show you what this looks like in the short axis plane. So here we are. This is the proximal humerus, and this is the biceps tendon in this groove. And this is a completely normal biceps tendon. It is happy in this groove, but as you're fanning the ultrasound probe, you're fanning it up and fanning it down, the biceps tendon goes from looking very hypoechoic to its normal appearance, very hyperechoic, to hypoechoic again. So this is just artifactual anisotropy. Now, when you put this into a long axis plane on a tendon, you'll see that it has this striate appearance here, very normal for a tendon. This is an Achilles. But you see that the Achilles tendon is somewhat oblique to the surface of the probe. And because of that, you're getting this artifact of anisotropy here. A little bit here, but it looks like it could be a tear right there. So don't let that fool you. So when we're looking at tendons, the main pathology that we are looking for is discontinuity of the tendon fibers. In addition to finding that actual discontinuity of the fibers, some other things that you can find that may clue you into the diagnosis is that you can sometimes have edge artifact coming from the edges of a torn tendon. This picture here is an Achilles tendon. So this is the tendon here. You can see the very fibrillar appearance of the tendon overlying a muscle belly right here. And then within this tendon, there's a hypoechoic, a little bit isoechoic area within there, but this is a tendon rupture of the Achilles. And so sometimes you'll also see a retraction of the muscle, and the edge that is the edge of the tendon that is on the muscle side of the picture. You'll see some retraction on that side, and within that space, often hematoma will fill it. And as we said, hematoma can often be hyperechoic to isoechoic and can really confuse you. So sometimes you have to look for these secondary findings such as the edge artifact or herniation of the fat up into the space. So what you see right here is actually the fat pad that sits behind the Achilles tendon, kind of herniated up into that space. Okay, moving on and talking about nerves. So nerves have a very similar appearance to tendons. I find that folks tend to confuse the two pretty frequently. Knowing your anatomy is going to help with that. They have a very similar appearance, though they tend to be less rounded. They tend to take on the shape of whatever fascial compartment they've been given to grow in. They are also subject and victims to anisotropy. So making sure that when you image, the nerves that you are perfectly perpendicular to them, whether that's in a short axis plane or in a long axis plane. And nerves almost always, not always, but very frequently, they're within the neurovascular bundle. And so you'll see the vein and the artery running along with them. Okay, so we've gone over the normal anatomy that you'll see for most musculoskeletal anatomy. And now let's get into some special cases. I tried to pick things that I find elevate my practice as a physician, elevate the patient experience. What's very different about doing musculoskeletal ultrasound is that unlike doing echo or a fast exam, you're not necessarily saving lives, but you're participating in improving people's livelihoods and improving the care of them immediately and over their hospital course quite a bit. One way that I like to use ultrasound personally, even at a tertiary care center, is when there's cases where the x-ray is taking really long time, or where the x-ray is inconclusive to find fractures. But in a resource limited setting, using ultrasound for fracture assessment can be key and critical. So we'll talk about the findings that you'll see. So the main thing that you're looking for is cortical disruption of that hyperechoic bony cortex that we saw, and also associated hematoma in the area can clue you in that there is pathology where you're evaluating. This has been around for a really long time. So the first time this was described in the literature was 1988. A physician published a paper about a neonatal clavicle fracture. And so they were showing the bony cortex here and then how this was moving with the respirations of the patient. So how accurate are we when we use ultrasound, particularly in the emergency department for diagnosing fractures? So the studies are a little bit all over the place, and so the sensitivity ranges anywhere from 64% to 100%, anywhere, and the specificity ranges anywhere from 79% to 100%. Um, Now, when we are looking at less so the subtle nuances of fractures, but just looking at the need for reduction, ultrasound can help with the identification of need for reduction in about 92% of cases. And when evaluating as you are doing a reduction, it is helpful for the adequacy of that reduction in about 92% of cases as well. But let's look at a case here. So this was a case that one of my residents had in the not too distant past. This is again a distal radius fracture. So we can see the bony cortex here, and then a fragment of bony cortex up here, and then more bone down here. So this is a very clear fracture. This one's not so subtle. When we just look through this image and look at all the other anatomy that we can identify, so we have our soft tissues up here, and then we can see a tendon running along right here, but then we still see this cortical break here. One thing that I think is worth mentioning is that as there is healing of fractures, you can follow these with ultrasound and actually watch the callus formation, which can sometimes be helpful in cases where you're not sure if the healing is adequate, or if they're going to need repeat x-rays to assess for adequacy of their healing. You can look at this area and see if you see some bridging callus starting to form. And this typically takes several weeks before you're going to see anything sonographically, but can be sometimes helpful. What I find most challenging looking at the literature is that it's a bit confusing because every study that's out there has a different cohort of patients, whether that's peds or adult or simple trauma or multi-trauma. They all take into account different types of fractures. There's feels like there's innumerable types of fractures out there that one could evaluate for. And then they also have all different kinds of setting and operators. So with such a with such a heterogeneous group of papers, I think it's very hard to synthesize what might what ultrasound might be most helpful for. And some of this is one of the best studies out there that I've seen. It's pretty new, actually, that looked at using ultrasound for suspected pediatric distal forearm fractures. Um, and this was published in the New England Journal of Medicine. And so they took children with isolated forearm injuries, those that had no deformity, and they randomized them to get ultrasound or X-ray as their primary imaging modality. If in the ultrasound group they identified anything beyond no fracture or a buccal fracture, if they identified any other type of fracture, that patient went on to still get an X-ray. And then they followed all of these patients for 8 weeks. And so they arranged this study as a non-inferiority trial. And so they did find that ultrasound performed non-inferiorly. But even though I like this paper and it was very well done, what's difficult here is that buccal fractures are very low risk. And so these are fractures that if they go untreated, in a lot of cases, it is identical outcomes also. And so I don't know that this is as much as I was happy to see like point of care ultrasound in the New England Journal of Medicine. I don't know that it informs my practice because these are the cases that the stakes are not very high. Um, so when it comes to how do we apply this in our routine use for diagnosis? I think that in a resource limited setting where X-ray might be difficult to obtain in a quick manner, it can be key. I also still use ultrasound in a reduction. If I don't have fluoroscopy available, then ultrasound can be your friend as you are trying to line up fracture fragments. Sometimes it can also be helpful to find occult fractures. A few weeks ago, I had a pediatric patient who came in with pain at the knee. X-rays were negative, and we ultrasounded and found a cortical disruption right at the tibial tuberosity. And so we diagnosed the patient with a fracture based on the ultrasound. When we looked back at the X-rays, you could then see the small cortical break that we had missed and radiology had missed on the initial X-rays. And also to, of course, why we love POCUS in general is we can decrease radiation quite effectively with it. So a note on using ultrasound for reduction. So this was one of the better papers that looked at this. Although I tend to think that they're like high level master because the images that they show, I've never obtained such beautiful alignment using ultrasound to guide reductions. But in this research, they looked at patients that had ultrasound versus standard care for reduction. They did not use fluoroscopy though, but they did use like repeat X-ray, and they could go and repeat a reduction if they needed to. And they found that rate of repeat reduction was much lower in the ultrasound group. So the ultrasound patients only had to have a repeat reduction performed 1% of the time, whereas in the group where they did not use ultrasound intra-reduction, they had to have a repeat reduction done almost 9% of the time. Though their study wasn't powered to look at this, they did find an incidental finding of a reduced operative rate in the ultrasound group. Now, I would take that with a grain of salt because they didn't design their study to evaluate for that. I haven't seen a study yet that really looks at a reduced operative rate when you're using ultrasound to guide reduction. But what they basically do is they take the ultrasound, and then as you're doing reduction, you're checking how close you're getting with these cortical fragments. Now, see, this is where I think that they're just like, either they're cheating and they're showing us an area with ultrasound where the fracture was not, or they're just such a high level master. And then here you can see the cortical break here. And then as they're doing the reduction, they're checking to see how they're guiding those fragments together. Now, this is something that I use on a very regular basis um, in my practice is using ultrasound for hematoma blocks. So same same scenario with our distal radius fracture that we've seen it a couple different distal radius fractures so far today. But you can see the cortical fragment right here, another one here. When we're doing when we're doing hematoma blocks without ultrasound, we're palpating someone's broken bone and swollen tissues to try and identify where the fracture is exactly, and then trying to put a needle into that space. With ultrasound, you can see exactly where the cortical fragments are. You can guide your needle exactly to those areas and inject your anesthetic of choice right into the area where the pain is the greatest. So you can kind of see the needle coming in a little bit here. And then as we look on the next images, we can see the needle really well here. They've directed it all the way up to where the cortical fragments are and where the hematoma is. So you know that you're getting a good block. Once I adapted my practice that I'm really only now using ultrasound for hematoma blocks and not doing them blind. The need for procedural sedation or other sedation for reduction has gone way down for me personally. I find that patients are a lot more comfortable and tolerant of the reduction, and because they're more tolerant of the reduction, I do feel like I can get a better reduction. And so another picture here of what that looks like. Sadly, I have to say there's not a lot of research done on this yet. Most of the studies that have been done, they look at ultrasound guided hematoma block versus sedation. That's not really the comparison that I would want to see. I kind of want to see more ultrasound guided hematoma block versus blind. Um, and they've looked at ultrasound guided hematoma blocks versus nerve blocks. So if anybody wants to do a research on this, I would love to see it because I feel like it's a big question mark. It feels in my personal practice and the practice of my colleagues that this is a game changer for patient comfort and success of pain control. But the data doesn't necessarily exist to support that. Like most things in life, like driving, walking, or putting needles into something, I think it is better to see than not to see. So I'm just going to keep using ultrasound for now. Um, I wanted to talk a little bit about image and needle visualization. Um, I bet all of you have done many ultrasound guided procedures in your lifetimes, and the seeing the needle is the key. It's the key and critical portion of the procedure is you can't really do much of anything if you can't see your needle well. And so you can see there's a big difference here between how well we see the needle here. We're just kind of seeing shadows than how we see the needle here. So some of the ways in which you can improve your imaging have to do with the angle of incination between your probe and your needle. So anytime you're having a very steep angle to your target with your needle, you're going to have um, inferior imaging than if you have a more shallow angle of your needle to your target. The ultimate goal is to try and get your probe surface as parallel to the needle as possible. This allows as much of the ultrasound signal to be reflected off of the needle and back to the ultrasound probe as possible. And if you can imagine in this scenario, your ultrasound waves are encountering this needle, but because of reflection, not all of the signal is going to make it back to the ultrasound machine. And so you're not going to be able to do the ultrasound transducer. And so you're not going to be able to see the needle as well. Um, So just an example here, same gauge needle, same tissue, different angle. And so here you can see almost a 90-degree angle. And so you can see the needle very well. And then here you have a much steeper angle to the needle and in less image visualization. So sometimes we don't get a great choice about the angle of attack that we have to take because of anatomy, because of where we want the needle to go. But by rocking the probe in order to match the angle of the needle, whether you're in a long axis plane or even in a short axis plane, by rocking the probe towards the needle so that you have um, more of a 90-degree attack, you're going to have a better needle visualization. Okay, enough on fractures and hematoma blocks. I'm going to move on now and talk about shoulder dislocation. So, ultrasound use for the diagnosis of shoulder dislocations and for the reduction of shoulder dislocations. Enough studies have been performed now on this that we are at meta-analysis level data, and it has ultrasound has adequate sensitivity and specificity to be used routinely for this. Um, I uh, I have been pushing hard for this in my emergency department, not because we don't have availability of X-ray, but because it's just so much faster to make the diagnosis. We have a process now at our institution where we have a physician in triage, and being able to use ultrasound to say, is that deformed shoulder a dislocation or is it not, is very helpful to put the patient into the right care areas to help get them reduced effectively. And so how do we do this appropriately? So you can choose either a linear or a curvilinear probe. There are different approaches. You can do a lateral approach, you can do an anterior approach. In general, what you'll see for the emergency medicine literature is a posterior approach. That's the approach that I learned. That's the approach that I use, where you have the probe placed on the posterior aspect of the patient. You have the transducer in a transverse plane across the posterior aspect of the shoulder. And you use a bit of anatomy tracking in that area to identify the glenohumeral joint. So first finding the scapular spine, usually still easily palpable, not on all patients, but certainly available sonographically, finding the scapular spine, using that to find the spinoglenoid notch, and then finding the humerus. So we'll walk through this little by little. So this is what your sonographic image is going to look like. We can tell a curvilinear probe because we can see this curved face here. We're on the posterior aspect of the patient. So we have to remember that everything that's in the far field is more anterior on the patient than posterior on the patient. And then this is medial and this is lateral on the patient. And so we have scapula here, and then we can see this little notching. Oop, I advanced too fast. There we go. So we can see this little notching, which is the spinoglenoid notch, and then leads us to the glenoid process, where the humeral head can then be seen articulating at the glenohumeral joint. And then here's where I find it can be very helpful, but at least wow patients, to show them as things move. If you have the patient then internally and externally rotate the shoulder, then you'll be able to see the humeral head there moving within the glenohumeral joint. So this is an intact shoulder from a posterior aspect. And then when we're looking for a shoulder dislocation, most of the time our shoulder dislocations are going to be an anterior dislocation, but every once in a while you'll see a posterior dislocation, and both of them can be diagnosed pretty easily with ultrasound. So from this posterior approach, you can see the scapula here, glenoid there, and rather than the humeral head articulating right with the with the glenoid, it's displaced more anteriorly. So we see this bony cortex here that represents the humerus, and you can see that there's a clear shoulder dislocation in here. So anterior shoulder dislocation. And then over here we have the scapula there, and then the humeral head is more posteriorly displaced from the glenoid. I often get the question from learners, like, how far does it have to be before you know that it is dislocated? And the best advice that I've come up with is if you draw a line from like scapula across glenoid, it should hit the bony cortex of the humerus. So if we look on an intact one, we draw a line from here to here, and then it'll hit the upper edge of the humeral bony cortex there. And the three things kind of sit in one line. But then when you come here, you can see this anterior shoulder dislocation. If you try and draw a line across, the humeral head is nowhere near where you need to be. And then here, if we draw a line across, the humeral head is too far posteriorly displaced. Um, the other brilliant thing about using ultrasound for the diagnosis is that you can easily, pretty shortly after diagnosing the shoulder dislocation, do an intra-articular block and get them some pain control. So another example here of an anterior shoulder dislocation, we have the humeral head here, and then you can see the glenoid, the spinal glenoid notch, and then the rest of the scapula over there. Just to give you an example of what an effusion might look like in this area, if you ever needed to diagnose an effusion in this area or tap an effusion in this area, here's normal side with humeral head and glenoid, and then humeral head with an anechoic area representing a joint effusion there. One thing I wanted to bring up is I've spoken a lot about like the glenoid notch. So sometimes if you are more superior or cranial or caudal along the scapula or along the humerus, you can falsely make an assumption that there may be a dislocation if you're actually looking at the humeral shaft instead of looking at the humeral head. And so always looking for the notch is going to tell you that you're at the right level, that that's right where you should be seeing the articulation of the humeral head with the glenoid. So doing a shoulder injection here, we'll walk through this step by step. This is an absolute favorite of mine. My favorite story to tell my residents about this is I had a patient who we diagnosed a shoulder dislocation when he first came in, and then injected his shoulder, and then he was roomed, and he was going to go get his x-ray, and next thing I know, I turn around and he's just leaving the emergency department being like, "Bye doc, I'm all better," because his shoulder had just fallen into place. He never got an x-ray, and he was waving goodbye with his affected shoulder. So when you want to do this, you'll have your probe on the posterior aspect of the patient again. Same location where you're making your diagnosis of the shoulder dislocation, and then coming in more laterally to inject. So image here, we can see the scapula, humeral head, and then you can see the needle coming in. The nice thing about this particular view with the posterior approach, and then with the ultrasound, and then a lateral approach with the needle, is that you are matching that the angle of the needle that you want most. You're able to use the curvature of the shoulder in order to have a nearly parallel probe surface and needle, so that the needle really shines. And then you can inject your anesthetic right within the joint capsule, and they typically have very good pain control with this. So I threw in knee arthrocentesis since we are talking so much about putting needles into joints and places. Um, I know that most people learn how to do their first arthrocentesis of a knee blind, and then most of the time it's so easy, and then people are like, oh, I don't need ultrasound in order to do this, but it's easy until it's not, and then you'll have cases where you can't get fluid, or they have very small amounts of fluid, or they're just screaming in pain. And so ultrasound guided knee arthrocentesis is a huge benefit. So I'll walk you through how to do this. Um, the studies that are out there do show that it decreases pain, increases patient satisfaction. Most of the time, more fluid is obtained. Now, the improved success really depends on operator, setting, and how they define success. Um, in my experience, it's not necessarily faster to be doing it with ultrasound, especially when you include the setup and everything, but I find that the patients are much happier, and I am much happier, and the cases where, you're trying and not getting any fluid are few and far between, almost never when using ultrasound. So just walking you through the procedure, briefly begin with your long axis view in the suprapatellar area, and then turn into the short axis plane within the knee, and then insert your needle in plane with the ultrasound probe from that short axis plane. So I'll walk you through some of what those images might look like. So the probe is placed in the suprapatellar space. I typically use a linear probe for this. I find that the anatomy is close enough that you'll be able to see everything, unlike the shoulder where it can be somewhat distant. Where I often recommend using a curvilinear probe, but here a linear probe is sufficient. And then you'll get a view that looks just like this, where you see this very fibrillar appearing quadriceps tendon. You can even see a little bit of anisotropy right there. And then over here, this bony cortex that you see is patella. And then this other bony cortex that you see right here is femur. So this patient has no joint effusion in that area and looks very normal. And here's a more dynamic look at it. So patella, femur, quadriceps tendon right there. And then here's a patient that has a large joint effusion within that space. So the fluid will come in between the quadriceps tendon and the femur and appear, in most cases, hypoechoic, though if you have a lipohemarthrosis, you can see hyperechoic areas within it. If you have a hemarthrosis, you can see like mixed echogenicity within it, or fibrin strands. But for the most part, the simple joint effusions that we are encountering are going to be very anechoic. In this image, you can see they're sliding all the way up, and then translating their image down towards the patella from the most superior aspect of the suprapatellar bursa. So what we're imaging here is this space. If you get a cross section of the knee, and so this suprapatellar bursa right here is less surrounded by bone than a lot of the other areas. And so much easier to tap sonographically. So you're not fighting bone shadow, you're not fighting bony prominences, and yet it's contiguous with the joint. Now, sometimes if they have very small joint effusions, you might not get a lot of fluid going up into that area, but you can take your hand and kind of cup the lower part of the joint, and that'll help translate the fluid up into that suprapatellar bursa if you need it there. And so then when you go to tap the joint, turn the probe from that long axis plane along the quadriceps tendon into a short axis plane on the quadriceps tendon, and then your needle can come in laterally, again, so that you can get nice needle visualization and have a perpendicular beam to needle, parallel probe surface to needle, so that you can optimize your needle imaging. You can see needle tip right there. So needle in the space, we're in a transverse plane in the suprapatellar bursa right here, and then drawing some fluid out. I put this one in because this was a case that I had, like, I think just last week, where it's big joint effusion here. You can see this, there's like two fat pads that the effusion will go in between. And so like the quadriceps fat pad, and then there's a prefemoral fat pad, and then you see so much fluid up into that space. Um, this patient was incredibly hesitant to have us tap their knee, and we definitely could have done it blind. There was so much fluid in there, but he was really grateful that we could do it. With ultrasound, and he watched the whole process. And by doing it this way, rather than putting the needle in and encountering someone's bone, you're only encountering the joint space, and so it tends to be much more tolerable for the patients than otherwise. Um, okay. I know I've given you guys a lot. I want to tell you about just one more thing that you can use ultrasound for is femoral nerve blocks. We do this routinely in our emergency department. We have had great success with this. I'm still trying to teach everybody in my group how to use it. So there's a learning curve associated with it, but the benefit to patients is enormous. Um, the doing a femoral nerve block for femur fractures is much safer than using opioids. Their pain control is so much better. I had one of the attendings texted me and said, he had to give a patient Narcan because he gave her too much in opiates for her hip fracture. And then one of the other attendings walked him through doing a femoral nerve block, and he was like, I'm never going back. But more than that, these patients have better outcomes at 30 days. They have decreased delirium in hospital, and it's overall much better for them. The level of evidence for doing early femoral nerve blocks on hip fractures, femur fractures is at a very high level of meta-analysis now, even Cochrane reviews. So when you do these, you're going to have an anesthesia on the entire anteromedial aspect of the thigh down to the knee. I think what's important here is looking at the area of anesthesia that you'll get of the bone. And so nearly the entire femur is covered. You're going to have some areas, particularly on the condyles, which will not be covered. It's not perfect for knee joints, but it's fantastic for any sort of hip fracture, intertroch fracture, femoral neck fracture, or femoral shaft fracture. Now, contraindications that you want to try and avoid is any sort of crush injury. The European guidelines for doing femoral nerve blocks, if you're concerned that there may be compartment syndrome, are very different than the American ones. The Americans tend to be a lot more conservative and just say, like, don't do a nerve block if you're concerned that there may be compartment syndrome. And then anticoagulation is a bit of a plus or minus, taken into clinical context, a little bit of a relative contraindication. Um, this is a nerve block that's relatively high volume. Our standard is to do 30 mLs of anesthesia because you want to have a certain amount of translation of fluid around the nerve. So checking your anesthetic and the safe dose for the patient in front of you is absolutely necessary every single time. This is the app that I use to do it. I put the QR code there for you so that you can get the app yourself. My personal choice is to use ropivacaine because the difference between an effective dose and a toxic dose is very broad, unlike bupivacaine, where the difference between a toxic dose and effective dose is very narrow. Most of the time, the the complication of LAST is going to happen when using bupivacaine. When they've done large reviews, bupivacaine is the most likely culprit for instigating LAST, which can be incredibly dangerous. So, as you probably already know in your practice, LAST is local anesthetic systemic toxicity, whereby patients have a systemic response to the anesthetic, which can start with sensory derangements, progress to CNS symptoms, and then progress to cardiovascular collapse. The truth of the matter is that it frequently progresses through these stages in the space of just a couple minutes, and so you probably won't see all of them, and it can present just with the cardiac arrest, unfortunately. There's still a very low incidence with peripheral nerve blocks, but not none. The treatment for LAST is intralipid, but it's so rare if you're calculating your doses correctly, um, that you should never encounter it within the course of your career if you're doing things correctly. Now, doing a femoral nerve block, needle choice is important. Ideally, you're choosing a non-cutting needle. Ideally, you're having tubing attached so that you can administer the anesthetic, and have the needle and the syringe separate from one another. This can be IV tubing. Nerve block specialty needles are great, but we don't always have them. So a spinal needle with IV tubing, or the little pigtail tubing that they'll use on IVs, can be used. The key and critical portion of the procedure is to flush all of the air out first, because if you go to do an ultrasound guided nerve block and there is air within the tubing and you try to then inject the anesthetic and you haven't flushed it out yet, you're going to obscure your entire view. So, looking at the anatomy within this space, we have nerve, artery, vein, right along the inguinal ligament. My experience is that much of the time, folks are doing their femoral nerve blocks too far distal, and need to get as close to the inguinal ligament as possible in order to do an effective block. Luckily, as I understand, most of you are in acute care, and this anatomy is very similar to you. You know this anatomy from placing central lines, for placing arterial lines or sticks, and so you know this anatomy. So we have the femoral vein here, common femoral vein here, and then the superficial and deep femoral arteries. And then just lateral to that is where we're going to see the nerve. I'm going to play this image for you there. So coming across, and then here's our nerve right there in the little triangular shape adjacent there. So the nerve sits beneath two different fascial layers. So as your needle's going in, you're going to feel a first pop where you're hitting the fascia lata, and then you're going to feel a second pop as you're hitting the fascia iliaca. And I think that that is something that is under recognized as a most important part of doing the procedures, that you really should feel both of those gives as your needle's going in. Now, it's great to be able to do this with a two operator technique, where one person's handling the needle and the other person is handling the probe. That's not always possible. In my practice location, I often have a second operator, even if that second operator is often a nurse. But the needles tend to not move around all that much. And so if you need to do the needle and the syringe both with the same hand, it's possible. And so as you're doing this, you'll first identify the nerve, and then you're going to use ultrasound to spread the space open. If you're not exactly certain if your needle's in the right spot, using hydrodissection in order to be able to see where the fluid is going to go is incredibly useful. And so here we can kind of see this fluid is going in and it's kind of dissecting that space. So I would say they're a little bit too superficial to be getting the nerve because the nerve's down here and their fluid's kind of going in up there. So just walking you through one of these femoral nerve blocks, so we can see our artery here, we can see our nerve pretty well outlined there. The operators got their needle here. Um, I would say they probably should have started a little bit more lateral so they had a little bit more space to start with. They're trying to work their needle in. They are coming in underneath the nerve as best they can. So I would say they may be a little too close to the artery here, maybe back it up a little bit. But here's where they go ahead and inject a little anesthetic, and we can see it opening that plane there. So now the nerve's down here. This is sometimes difficult because as you're injecting anesthetic, sometimes it'll go within the muscle and everything will start to become more distant from your ultrasound probe. And so keeping an eye on your target anatomy can be a little challenging. And so here we have now they're in the right spot. So we can see needle tip there, and then we see nerve there, and we can see them just bathing the nerve in anesthetic. And these guys go a little crazy and they bring their needle even on the other side of the nerve and just fill the space entirely with anesthetic. My experience with doing femoral nerve blocks is that everybody is much happier. The patient is happier. The family members are happier. You as a provider are happier, and they have better outcomes. With their femur fracture of all sorts. Um, so I hope that through this lecture, I have given you some level of musculoskeletal ultrasound mastery. And so please go forth and ultrasound.